I'm so excited to be here with Dr. Gordon Gunn, MD. First met Gordon as a student in one of his presentations about cardiovascular health and hormone replacement therapy for women, and was absolutely fascinated by the presentation because it was so seemingly, to me at least, controversial. Gordon, thank you so much for joining us today. I'd like to start off by asking you a little bit about your background.
Sure.
Tell me what you've studied.
Wow. Okay. This goes back quite a ways. I trained as an obstetrician gynecologist and subspecialized in what has become oncology. I was the cancer surgeon. I did that for a long time. I was the chief cancer surgeon for the United States Air Force back in the late 60s, early 70s.
Wow, cool.
And so I started a private practice in Fullerton around 1971. Seems like a lifetime ago. But over the course of my career, focusing pretty much on GYN only and oncology, I began to expand the scope of the services I would offer my patients because I felt they really weren't getting them from their primary care. Mm-hmm. So I started doing more and more and more, and that led over the years, probably 2-3 decades into having the tools to do more in-depth evaluation, and ultrasound was part of that. And we could start doing vascular ultrasounds, and with that, could diagnose disease in arteries. Mm-hmm. And so that kind of, my background in cardiology and cardiovascular work kind of lended itself to that. So I really began to then, over the last couple of decades, expand into what's, I guess, referred to today as more of an integrative type of practice. Mm-hmm. And it's been an exciting journey. It really has. So I now look after the whole woman, if you would, and in the last few years, actually men too, who have come into the practice because everything we're going to talk about other than estrogen therapy really is applicable to men in terms of cardiovascular disease. Mm-hmm. So
how did it evolve into your current practice? You started out in what sounds like to me to be very different from what you're doing today.
Correct. Well, it's like a lot of things in life. As you go through, you have to, I think, kind of reinvent yourself to stay alert and continue to grow and learn. And it was kind of it was more of a reaction to what wasn't being done. 20 years ago, I would send patients in whom I would diagnose vascular disease in their arteries to the cardiologist to be managed, to be treated. And they just pat them on the head and send them back saying, Dr. Gunn's a gynecologist. Plaque is normal as you get older. It's not very much. Don't worry about it. And I knew that wasn't true. And so I know we don't have time to get into the whole cardiovascular aspect of this.
I would love to do another podcast on it, though. That's fascinating.
Well, it's in a way, it's a much greater magnitude of importance, more than what we're going to be talking about today, and the role of estrogen plays in that role. But that led me then, if they won't do it, I will, because it's a medical disease, and I started managing my own patients and grew from there. And I'll just quickly add that I'm absolutely convinced, my own experience, by following sequentially vascular ultrasounds, this disease is stoppable and completely reversible. And you could virtually almost eliminate cardiovascular events if people would aggressively go after it that way.
So, I think that's a fascinating statement.
Yeah.
So hormone replacement therapy.
Right.
And what were you seeing not being done in that particular part of your practice, among other doctors?
Well,
or should we rather start with the history of it?
it might be
well.
better to paint a whole broad background because I've been around long enough to seen this whole history from almost its beginning. Birth control pills were first approved by the FDA, I think, around 1960. Okay. Estrogen had previously been approved a decade before, for hormone replacement therapy in women. So I've been kind of part of the saga all these decades, and it gives me a good perspective.
Okay, so questions?
Yeah, no questions.
Well, let's start with the something you said in your presentation about life expectancy in the early 1920s, I believe, and how menopause wasn't a thing because people weren't living long enough. Can you kind of talk about that history?
Certainly. through the early 1920s, the life expectancy of a woman born at that time was about 50 years of age. So the whole phenomenon of postmenopausal life and medical issues that arise out of those years after menopause is really a phenomenon that occurred only in the second half of the last century. So 70 years, it really has been an issue. And estrogen was discovered in the 1930s, approved by the FDA, and I think in the 1940s became readily available and started being prescribed in the form of Premarin in the late 1940s. Specifically in women who have had hysterectomies or didn't have hysterectomies, they were just only given estrogen at that time to control menopausal symptoms primarily, and it worked. It continued to grow amazingly, so that by the 1990s, estrogen was the number one.
So 50 years of using that particular prescription?
That's correct.
Wow. Okay.
And so in the 1990s, it was the most commonly prescribed drug in the country.
Because women were living longer, right? So more women were having those symptoms.
And so doctors would be doing studies, on estrogen hormone therapy, and most all of them were observational studies, but they all were very positive for the most part. But I think it was around the late 1970s, there began to appear in the literature some questions of whether or not estrogen might play a role in breast cancer, might play a role in endometrial cancer, the uterine cancer. So there were questions raised about the safety, of estrogen possibly. And so that led the NIH, I think in 1991, to launch the what was become known as the Women's Health Initiative study.
Okay.
And so you want me to talk about
let's get into that study.
Move into that?
Yeah, let's get into that study.
Okay. Then this was a study that was designed to assess random assignment, of estrogen and progesterone combined. Those were two different arms of the study or groups that had to do with whether a woman had a hysterectomy, she'd be given estrogen alone. If she still had a uterus, she'd be giving estrogen and Provera, which is a synthetic progesterone. At the time the study was started, we didn't have the bioidentical progesterones we have today. And then the third arm of the study was a placebo. And supposedly you didn't know which patient was going to get assigned to which group, but if they had a hysterectomy, they were going to get estrogen or a placebo. So that was the group, but it was designed specifically to see what impact prospectively going forward estrogen played on the outcome of breast cancer, cardiovascular disease, colon cancer, osteoporosis, and they also were looking at things like diet and vitamin D and calcium and the role that it played. So you had these three groups. Before we go to 2002, when everything changed overnight, I want to point out some significant design flaws in the study because it definitely impacted what I'll be talking about in just a few minutes.
Millions of people it impacted, right?
Oh, yes. Yes. The study included about 168,000 women. And it was not just the United States, it was in Europe and other countries as well. So you had multiple investigators in these various localities that were recruiting women. And they were recruited, and the authors stated that these were healthy women, 100% healthy, had no diseases, no issues. Well, it turns out, though, that the average age of the enrollees was 63. Now, menopause normally occurs around 51 on average. So the average age of the woman, or the median age of the woman who was enrolled in this study, was 12 years postmenopausal, some 12 years after she had not had any estrogen in her system at all. First of all, they weren't healthy because I think it was like 35% of them were obese, another 34% were overweight. nearly 50% of them had high blood pressure, and nearly 50% were either smokers or ex-smokers. So this is not representative of the healthy perimenopausal woman just finishing her own normal menstrual cycles, moving into menopause at all. So you had this, what turned out to be a very distorted bias selection. Only 10% of the women in the study, as I recall, were under the age of 60. Okay.
Do you know why that happened? Like that kind of selection of the population?
Do I know? No.
Yeah.
But do I suspect? Yes.
Ooh.
What's your
What's your suspicion?
yeah.
Well, this is well known now and has been written and talked about. The lead author for the WHI study was a physician, a cardiologist named Jacques Rousseau. And he had been in writing in the 1960s when the study has already underway, saying that we need to put a stop to this bandwagon of estrogen, okay, and really assess, its role in breast cancer and heart disease. So we want to slow this down and basically stop this bandwagon.
But why would he wanted to slow it down?
That I don't know.
He just had a sense that there was some connection to cancer.
Yeah, it comes down to a belief system. Beliefs are really powerful. And oftentimes one goes into a study with kind of a preconceived idea of how you want the outcome to be. Mm-hmm. And that could influence your decision making either overtly or inadvertently. But it does affect it. Now, whether that played a role, I'm not in a position to really assess that. But I'm left with it. What we do know is what I said previously, that it was the wrong population, not a healthy population, okay, that they were studying the effects of estrogen because they weren't starting on a level playing field. So in 2002, and it was July of that year, I remember seeing on the evening news flash estrogen linked to breast cancer and heart disease risk. Boom. And then right afterwards, the article, there's a press release from the American Medical Association journal, JAMA, saying the same thing. And then the headlines went around the world. And it literally paralyzed people. I mean, they were shocked. It was the...
And how did it affect, so it paralyzed patients, how did it affect doctors? What were they doing?
Well, patients didn't know what to believe. All of a sudden, they're being told estrogen now out of nowhere. You've been told that it helps all these things. Now it causes cancer of the breast and it causes heart disease. Were dead in their tracks. They had really no place to go, so they panicked and quit. Doctors, uncertainty. They didn't know what to believe. Okay, I mean, this comes from the NIH. Okay, funded this study, and I'm told to the tunes of nearly $1 billion. It was the largest prospective double-blind study ever done.
Wow.
Okay, and so it must be credible, right?
Uh-huh.
And people interpret it that way.
Do you know how that was funded? It sounds
through the
expensive.
NIH. The taxpayers paid for it.
Wow.
Yep.
Fascinating.
Taxpayers paid for that.
And
study.
horrible.
I know.
Huh. And you were practicing at that time. So
Yes.
what was going through your head?
Well, I was shocked. I also didn't really believe what I was reading as being truthful.
Well, why is it? Why didn't
Because
you
I've
believe
been treating women for estrogen for so long, okay? Never saw any increase of anything, okay? Only the beneficial effect from it. And so
So clinically speaking, you were like, well, this is the opposite of what I'm experiencing.
Correct.
Okay.
So I was able to get the hold of the whole paper that was published. That's when I learned more about the two arms, estrogen alone, estrogen plus progesterone. And in their own data they published in that initial article in 2002, the incidence of breast cancer and heart disease was actually less on estrogen by itself in that average age group of 63, which was really amazing. It only was raised slightly, and I mean slightly by a handful of cases, because it never met any statistical significance. It was represented as it was black or white, fully statistical, and it wasn't. It was a lie. And so, people didn't look beyond that. And it was over time, these statements were slowly retracted. Okay, and in 2017, about a year and a half ago, the same authors that wrote the original one in 2002 published an article that basically said everything we said before was really not true. There is no increased risk with breast cancer. This is using the WHI data now.
Wow.
Just that data alone did not increase breast cancer, did not increase heart disease. Okay, in fact, it did lower incidence of osteoporosis, of colon cancer, that were statistically significant. So, but there was never an apology a year and a half ago over what they had done. So you have a generation of women that have basically been fearful of, have gone without, had stopped their hormones. You mentioned a few moments ago, I think at the time the WHI study was published, there were something like 60-some million women in whom Premarin prescriptions were being written in the United States alone. 2 years later, it had dropped to 20 million. So over 40 million women who had been on estrogen stopped. Now, since 2002, you have a whole generation of additional women who have been denied, okay, the opportunity to go on estrogen therapy for the most part.
Because at this stage, recently, MDs, after so many years after the study, have, theoretically educated themselves, and they are of the opinion that it's dangerous. And the patients are getting that information. Is that kind of what's happened?
Well, yes and no. I mean, since then, this uncertainty that developed, understandably, almost overnight, the governmental agencies, okay, this is the governmental agency that sponsored this study, medical schools and medical centers, okay, and medical insurance companies, all of a sudden said, no estrogen, it causes cancer and causes heart disease.
Wow.
Okay, so it stopped being taught in medical institutions in the United States. Okay? So you have a generation of physicians
and there's a huge financial impact, negative financial impact as well, to companies that have a vested interest in making sure that we're healthy, right?
That's
like
right.
the insurance companies.
That's right.
I mean, theoretically, they're interested in us being healthy, but
so the standard of care that was giving estrogen prior to 2002 did a 180 after 2002. It was no longer accepted the standard of care as dictated by the government, insurance companies, and teaching institutions. Okay, so who are you going to believe? As a woman, okay, you're caught in this throw. Who are you going to believe? And so, because it was a prospective, randomly designed study, it automatically had validity, and people believed it. But they never brought to the forefront all the data that was coming out. When this study was published, it was released only by a handful of all the investigators. Most of the investigators had no knowledge that this was going to be released, or they were stopping the study. Had no input on what was put out in 2002. And there have been some pretty blistering recordations of their comments and what really went on behind the scenes and how wrong this was. Okay. At the end, I can give you a new reference that discusses this subject in depth and gives you all those references in there, so anyone can go and learn themselves now. But it was to me, I always felt it was a tragedy.
What were you doing during that period of time between 2002 and 2017 when the entire world of medicine was just off the radar, right?
Correct.
It wasn't available from your insurance company, and doctors weren't taught anything about it.
Right. Well, I became an instant outlier because I believed in the importance of it. And I didn't believe the data. I really didn't. And so my patient population trusted me, and almost all of my patients remained on estrogen.
What are the issues that you would face as a doctor in going off of the recipe book, so to speak? Are there any potential legal ramifications, malpractice challenges, anything like that?
Well, anytime I think that a doctor is faced with what's the standard of care when you have an adverse outcome, opens up the potential of the litigious issue for them. And so,
just so I understand what you just said, if you're treating someone for low sex hormones, a female, 55 years old or whatever, and she ends up with breast cancer, during that period of time, you were at a higher risk of being sued as a doctor because that would likely be attributed to your hormone replacement therapy.
correct.
That's scary.
Yeah, but
What?
but I didn't believe it was true. I mean, and I felt that there was enough outside the world of WHI. There were lots of other studies that had been going on for a long time, and in continuing at that time, that showed just the opposite.
Okay.
There were studies that showed the positive benefit of protection of heart disease and stroke. That there really were no studies that ever demonstrated an increased risk of breast cancer. And so, we can talk about what we know today in 2019, because not only WHI study data has been continuing to be looked at, and that's all been neutralized, so there is nothing negative coming out of that data anymore. A lot of other really well-designed observational studies have really shown what the benefit of estrogen really is. And I think we probably should focus more going forward in our talk this morning on what's in it for me? What's the benefit? Why should a woman open the door to reconsider hormone therapy? If nothing comes out of this today, if we can communicate to the women who listen to this in the future that don't be blinded by myths, okay? Don't let that negativity influence you. At least be open enough to seek what the truth is, what is really accurately known today, and why it's important for you, not only your current sense of well-being, but your long-term health.
Okay.
And I can kind of quote you all the statistics that we know pretty valid and constantly reproduced as to being valid for you.
And that's why we appreciate you being on this show to talk about this in depth. As a newer doc, I can definitely confirm that all of those things that you said about us new docs being scared off of hormone therapy, everything I learned from hormones and hormone replacement, I've had to actually seek on my own in continuing ed. Many of the patients have not had any sort of access to this, and unfortunately, there's just not that much media coverage. So you spreading the word, I mean, we really appreciate it. I've told many of my female patients, they're like, hey, we're going to do a podcast with this doc who can talk about this in depth better than I can. So that's,
Well,
definitely.
it's sad, but good news doesn't sell.
Oh, wow.
But so Alice, when you see female patients that are postmenopausal or even perimenopausal, what do you is it the general consensus among that population that hormone replacement therapy is scary?
Yeah. Every single one of them.
And
in
Dr. Gunn,
fact,
you see the same thing, I'm assuming. So.
Sure. I've had patients who will say to me that they had, this is several years ago, but their family doctor internist would not take care of them anymore if they didn't stop their estrogen. They didn't want their name linked to that patient who was taking hormone therapy as if he approved it.
Okay, and presumably that is still going on because not all MDs, I would guess, at the point in time in 2017 when this was entirely debunked, they may not have been aware, right? Or is there some magical system for all MDs to instantly get new information populated?
Well, the system basically is you're on your own. I mean, most states, have what's called CME or continuing medical education requirements within the specialties or fields that you're practicing. And even what's reported today is oftentimes a rehash of old information.
Okay.
But the data that I'm talking about is readily available. I mean, the authorities for all this is voluminous, and it's pretty darn consistent favorably, even down to the role of estrogen in breast cancer in patients who've had a history of breast cancer. women have just been scared to death.
They have been?
They really
Yeah.
have been. And
So-
it's just wrong.
Before we get into hormone replacement therapy, let's talk about menopause. What is it, and what's going on,
Sure.
and what does it look like to the outsider
Right.
in the relationship?
And just keep in mind, I think I think our listenership is about 50-50 men and women, maybe a little
Yeah,
bit
so
more
the
men.
dudes need to know too, right?
Like this is mostly for the dudes because they will look at their poor wives and they're like, "Oh my God, what's happening?" And they're probably thinking she's probably going insane.
Listen up, Jess. This is you in the future.
Well, before I forget, if I can let patients know or individuals know where my website is, they can go there because there's a particular testimonial that's written. I have on my
Absolutely.
test site. It was written by a patient of mine who was sent to me because nothing else was working, and she was a very, very successful businesswoman, had her own corporation, was about to lose it. She was under the care of 4 specialists, and I was on multiple medications. And when I got her to agree to go off of everything she was taking and let me just put her on bioidentical estrogen for a month, she did a 180% turnaround. Everything cleared. All her symptoms went away. She said, "I have my life back." That's pretty dramatic, and because it was so dramatic, for 2 reasons. One, there are many women who experience the same things that she's experienced, that she wrote about, but it's also representative of the ignorance that exists in the medical community by 4 specialties that never entertained at all that the estrogen might play a role or would be beneficial for her.
Do you mind if I ask, like, what pharmaceuticals she was prescribed to treat an estrogen deficiency?
You know, Alice, I don't recall. I know that she was getting drugs for mood, depression, sleep, arthritis.
Wow.
Okay. Because estrogen deficiency can mimic every one of those. And at some point, probably ought to go through and just
Yes.
read
let's
off
get
a
into
list
that.
of what symptoms can be when we get
Yeah.
there.
Yeah,
But
excellent.
you asked the question about what is menopause. Menopause basically means, by definition, the cessation of a women's menstrual periods for about a year. Average age around 51.
So if it's gone for a year, your period's gone for a year, that's official. You're in
Right.
menopause.
And over 2 million women today in this country reach menopause every year. So we got 16 million. We have almost another 40 million women since the WHI study, in addition to the 40 million women who stopped, okay, that have been estrogen deprived this whole time. And it's had big consequences. But we talked about how it's only been a second half of the last century phenomena that this has really occurred. You want to go into you want to
Yeah, let's talk about the symptoms.
Yeah, the symptoms of menopause. Or
What-
perimenopause.
Yeah, what starts to happen?
We'll move down there. They're really, I kind of categorized them into kind of 3 groups. In medicine, we call vasomotor because it affects your skin and your body temperature. But they're manifested in what's referred to as hot flashes, perspiration. You know, a woman's hot in the room, everybody else is freezing to death. Okay. Night sweats. A woman can wake up during the middle of the night and be drenched. Have to get up and change the sheets and change the night clothes. It can be so bad. So these are the symptoms, okay, that women typically will have. Not all women have these symptoms, by the way. We can talk about why later, but this is a major one. But there's a lot of other more vague physical symptoms. Palpitations, okay, joint pain and achiness, muscle pain and achiness, dry eyes, the more frequency of urination. You know, the vaginal tissues and the urogenital tissues are 100% dependent on estrogen to function normally. So they do become atrophic.
What about your brain?
Funny you should ask that. There's a whole litany, okay, of symptoms that have been tied to this. Irritability, just lethargy, just mental fatigue, anxiety for no apparent reason, mood swings, tension, just feeling tense, the irritability that women and they don't know why. Everything seems to be okay in their life. Though rationally will say, I'm happily married, my kids are doing okay, amazingly, but I feel like I'm going to jump out of my skin. The lack of focus, mental fog, they call it brain fog, short-term memory loss is a really big one.
Wow.
And it results out of the sense of not being in control. I know what's happening to me. I'm losing control. Depression as a consequence is understandable.
Mm-hmm.
And there's also a decrease in the sex drive, the libido, associated with this. So, you have this conglomerate group of symptoms here that are really ill-defined, and women are treated symptomatically to try and treat all these symptoms without going to the cause. Years ago, I had a lady came in after she had been on replacement estrogen for about a month and said, Dr. Gunn, it's like you've taken Windex to my whole world. The mental clarity that I see today, I can't believe what I was putting up with because I didn't know the difference.
Wow. Is that because it's a gradual change?
Can be. Yeah.
But some it's
right.
much more
Yeah.
short term, like it happens quickly?
It can happen very quickly.
Huh.
It can. The ovary can just fail one day, and literally, and women are in menopause fast.
Wow.
Okay.
And these symptoms that you're describing, those remain from that point forward?
If you're not treated.
But so the medical community typically is treating those symptoms,
correct,
and not the downstream.
And that's what the insurance companies today, including those even Medicare, says estrogen can be used for women who cannot control bothersome menopausal symptoms, but for the shortest time necessary, and then they need to come off. And the stupidity of that statement is that you can take an 80-year, I had an 80-year-old patient once who went off her estrogen a long time ago, who now is dying because she's having hot flashes, night sweats, and all her old symptoms back again. Mm-hmm. It's a myth that only lasts for a couple of years and you don't have to worry about it anymore. Completely. And if you understand that estrogen is a natural bioidentical hormone, its one of the principal roles was in reproduction, okay? And so it also, though, affects all the woman's body cells because what's called estrogen receptors, these are like little landing sites on all the cells of your body, Alice. That estrogen.
I have some of those too.
Yeah, you do.
Oh yes.
You have estrogen receptors, just like testosterone in women and men are receptor sites. A receptor site is where a hormone produced somewhere else travels in the bloodstream and attaches to those cells, and in so doing activates those cells to be healthier. Now, many of the cells of the body can survive without estrogen. Some of them can't. And I mentioned previously the vaginal tissues, the lower urogenital tissue. Mm-hmm. But it's turning out that probably we know now that the blood vessels, the lining of the arterial walls and blood vessels, are very estrogen dependent because it affects the elasticity of that wall and the health of that lining. Okay, the brain, huge. When I go through the benefits of estrogen now, long-term studies, I'll give you some statistics that show why this is so important. So estrogen is a very important natural hormone. Let me give you an analogy. Alice, let's say you had to have your thyroid removed for some reason, right? Mm-hmm. Okay? Yeah. Well, you can't, as you know, as a physician, you can't survive without thyroid hormone.
No.
Yeah. And so the doctor would put you on thyroid. You'd want to be on thyroid, okay?
Yes, absolutely.
Okay, on that for you. It's a natural bioidentical hormone that's there for a purpose. Estrogen is a bioidentical hormone that all your body cells react to normally. It's nothing foreign about it. It's not like a drug, okay, that is the body doesn't know what to do with, okay, like most drugs are. So it's a very natural thing. And so when you deprive it, for a woman that wasn't going to live past a few years past postmenopausal, in the mid last century, now is living average age when a woman born today is about 80, okay, 30 years postmenopausal, okay, and so women are being subjected to 25 to 30 years of their lives deprived. And we know what's going to happen statistically to her by not being on estrogen.
Long term. And what?
Short-term symptoms, long-term physical changes.
Okay. What?
And that's really important because, we only know kind of what we feel, right?
Mm-hmm.
We don't know what's going on with our heart. 50% of individuals, men and women, who have their first heart attack are, quote, in good health, have no knowledge, no forewarning, and boom, drop dead from a heart attack, okay? So our bodies don't tell us things, okay, that are wrong inside until they go wrong. A woman falls and fractures her hip. Lo and behold, she's got advanced osteoporosis, okay?
Started a long time ago.
Yeah, she didn't know about it, wasn't tested as it should be. That's what happened. But the short-term symptoms are reversible. And they're reversible, and they stay that way as long as a woman continues on her estrogen. But while that's taking place physiologically in her body, all those estrogen receptor landing sites are being fed by bioidentical natural estrogen to allow them to function normally. And over 20 years of estrogen therapy, we now know what we can pretty safely predict is going to be the outcome of the women who are on estrogen versus who have not been on estrogen.
Now, depending on some medical kind of organizations, there are some people who say that a woman should not be on hormone replacement for longer than 10 years. What are your thoughts on that?
That's somebody just made that up.
Oh, gotcha. And I think Kaiser even says it's nothing beyond 5 years.
Yeah, they just made it up.
So it's just arbitrary.
It is not rooted in any evidence at all. When the authors a year and a half ago came out with their updated position that turns out that we were wrong, that estrogen doesn't cause the things we said it did, there's another organization called the North American Menopause Society, or NAMS for short. And NAMS is looked at as being like the authority for direction that everybody takes, okay, their medical, for affecting women, directions from. NAMS came out with a number of things recently. And let me look at this, and I can kind of tell you what they are. But specifically, they said, everything that we said in their prior position statement from 2012. They give a position statement then that outlined estrogen only be used for control symptoms for the shortest period of time. Period. That's it. Now say everything we said prior to that was invalid. Invalid was their word. We were wrong. Okay.
Nicer way of saying it.
It turns out further that there is no evidence that says a woman should arbitrarily stop at the age of 65 like Medicare says. There's no evidence to support that. So even 10 years, there's nothing to support that. Nothing. Even in women who test positive for BRCA1 and BRCA2 for genetic risk, okay, for ovarian cancer and breast cancer, women will have their ovaries removed before menopause because of their high risk of getting ovarian cancer, should be on estrogen, even though they carry the BRCA gene and they still have their breasts. The data says it's 100% safe. There is no increased risk. But try telling that to a lady today that has test positive for BRCA1, 2 and had her ovaries out.
No.
It's very sad. It breaks my heart because that's how ingrained this belief has become entrenched in the last 17 years. And it's going to take a long time to slowly undo it. And it really is going to come from women seeking answers and getting information to reassure themselves. And all things that change, I think, come from the grassroots anyway. Okay. And in this case, it'll be the women who basically make this change, but they should for the right reasons.
So we were talking about some of the physical changes of the lack of estrogen. So you talked about vaginal atrophy. So most of our viewers are not going to know what that is.
And this is the stuff that happens much more slowly, right?
It does. Yes, it does, Todd. These changes occur, and not all women experience everything.
Gotcha.
Okay, they don't. But the majority of women, after a period of anywhere from 2 to 4 or 5 years, sometimes after menopause, the vaginal tissues become paper thin. So when they do, they become more susceptible to infection, trauma, intercourse becomes very painful. So it's not uncommon to have women in the postmenopausal years relying on some type of water-soluble lubricant just to tolerate intercourse.
Jeez.
Okay?
So sad.
And because they know it's going to hurt, it's hard for a woman to get sexually aroused knowing what's coming, so she doesn't lubricate. Okay, so it's a kind of a cascading negative waterfall that affects them really in an adverse way. That affects their marriage. That affects that intimate relationship. Okay, I mean, that's just one example of the cascading effect that this impact has had for the last generation.
But what about the cognitive changes and things like Alzheimer's and dementia?
The specifically with cognition, dementia, and Alzheimer's disease, there are prospective studies. The two big ones came out of Utah and the other one came out of Norway that showed clearly that long-term estrogen replacement therapy, long-term being more than 20 years of use, had upwards of a 40 to 50% lower incidence,
Wow.
okay, of cognitive decline, including Alzheimer's incidence. Lower. Okay.
So when you see a when you have a, say you've got a friend who's 70-year-old woman, can't remember where she puts her keys all the time. Do you attribute that to low estrogen, or is that too simple?
It's too simple.
Okay.
It's a multitude of factors that enter into that. First of all, people worry about, becoming demented, losing their memory. As we age, it's normal to become forgetful of things. I mean, you might forget where you put your car keys, but if you don't know what the car keys are for, then you have an issue. Okay? Right?
So it's good.
It's
funny.
kind of all relative. So some forgetful. Most of it, our brain is filled with so much stuff. There's so much input going on all the time that it's common and to be forgetful about certain things. You can't recall something. Right? And does estrogen play a role in this in women? It sure may.
Mm-hmm.
Yes, it may.
Okay. That would be one of my biggest concerns as I age, is losing the sharpness that I currently have.
You bet.
Yeah.
You bet.
And so you
want to put you on estrogen too?
maybe
He has enough.
I have the
He has
receptors
enough.
for it.
But just all kidding aside, it brings up a reciprocal important point for men, and that is your testosterone levels need to be checked, just like a woman's levels need to be checked. We know a woman's ovary isn't functioning, but the testicle can last a lifetime. But men commonly, as they age, will have declining levels of circulating testosterone, and that has negative impact on them.
So I do have, again, there are some concerns about, I think it was recently they were saying that it is probably not a good practice to start a woman on hormone therapy 10 years post-menopause. What are your thoughts on that? If a 65-year-old woman who is completely past it, never went on hormone therapy, she's 65 and she says, I really want my brain back and my libido and everything else, would you start her on hormone replacement therapy?
Yes. There's one caveat, though, in this regard. The only thing that I can find in all the research data that I have access to that one would put into a potential risk by starting estrogen is in the woman who is a decade or two postmenopausal and she goes on estrogen. There is a slight, and I mean it's very slight, but it's a very slight increase in a cardiovascular event like a heart attack. And that only occurs in the first year that they're using estrogen. Now, the supposition is that we know that estrogen has a lot to do with the health of the artery wall and the elasticity of the wall itself. So, estrogen now, let me put it this way, the wall now, the artery, is now exposed to estrogen for the first time in 20 years, okay? It's going to now react to this. And so this initial reactivity is theorized that it may upset the stability of existing disease that exists in the arterial wall, the atherosclerotic plaque, as we refer to it, that allows that instability to maybe trigger, an event. Okay,
And that's a theory?
it's a theory. It's a theory to account for a little blip increase that occurred in the WHI study on women on estrogen only in that first year. But these were in the older generation patients, older age patients rather. After that, there is no increased risk. That's the only one. So before starting a patient on estrogen at the age group you define, I'd want to have a cardiovascular workup on her. I want to know, where are we on this. I want to make sure she's on a mild anticoagulant, like an aspirin tablet, baby aspirin every day, before I put her on the estrogen. I want to be proactive.
And those things would be a short-term solution while they're adapting?
That's a whole different subject about baby role of baby aspirin and its long-term benefits. But yes, I would keep her on it. I would keep her on it. But all the other reasons, the extent that she has so much bone loss, or that she's had physical changes in her body, the loss of elasticity in the skin, wrinkles. I mean, everything that you see the outcome of women not being on estrogen, that's not going to change, except you can lateralize it and stop it from continuing to progress.
That's right. So you're basically saying that you can't fully reverse those kind of changes, but you can prevent it from progressing.
With an exception. The exception has to do with the same your genital tissues, the vagina. You can take a lady who has paper-thin vaginal wall, can't have intercourse, put her back on her estrogen, whether it's topical locally or whether it's systemically, she takes full replacement, and within 2 to 3 months, those tissues will regenerate just like they were when she was having regular periods.
Amazing. Very
Speaking of periods, does the period come back?
If she has a uterus, the potential is always there. So to obviate...
So you can be 75 years old and having a period?
You could if you were only given estrogen by itself.
Okay.
And so the appropriate administration of estrogen is to combine it with a progesterone, a natural bioidentical progesterone, that taken together inhibits estrogen's ability to stimulate the lining of the uterus to grow. If it doesn't grow, it can't bleed. And the same thing is true with uterine cancer. It was correct, the observation in the 1980s and 70s, that women given estrogen all by itself with a uterus had a slightly higher incidence of uterine cancer. It wasn't being protected. But you protect the uterus today. So I've never seen a patient in my care, even as a cancer surgeon, ever have uterine cancer on hormone therapy, because she has always been on progesterone with it.
Okay. And so some of these things that you reviewed, the common symptoms of menopause, do start to reverse. Sounds like no matter what the age, just to a lesser degree if they're older.
Correct.
So things like heart palpitations, skin changes, joint pain may become minimized but not go away, right? Or become lessened, possibly.
If it's... Let me answer your question this way. Symptoms, as you know, Alice, can be anything that someone is aware of, that's occurring in their body. So when I'm going to start a patient on hormone therapy, I have her go to my website, print this article, and where all these symptoms are listed, and highlight everything that she feels she's experiencing, and to write anything on there that's not listed that she's experiencing. So you have a master symptom list. Put her on bioidentical estrogen. A month later, come back in and bring that list with you. And before you come in, I ask her to highlight everything that is now substantially gone. What I've effectively done is taking a master symptom list and divided it into 2 parts. One part that obviously is estrogen-related symptoms that are now controllable, and you can remove those, and symptoms that have nothing to do with hormone replacement therapy. So the evaluation of those symptoms can go down the right path and not get sidetracked. So we know exactly what symptoms were treated, and then I treat the level of estrogen replacement to control the symptoms. The main one is the hot flashes and night sweats. And that varies from woman to woman because of a whole another subject called the blood-brain barrier. We don't know how to measure this in the brain today, but most women have a low threshold for estrogen, so it doesn't take very much to get into the brain to control their symptoms. But sometimes the women will have very high thresholds, and you have to give a much larger amount of estrogen in order to do that. Okay, that's why estrogen therapy has to be individualized. One, you just can't give a prescription to somebody, and it needs to be with somebody who knows what they're doing.
Individualized and then monitored, right?
Absolutely.
Because there, I'm assuming, will be changes
over
time.
What I found is that once a lady has on a hormone replacement therapy, she's not having any menopausal symptoms, she's fine with it, that's pretty much it for the rest of her life.
Okay.
Just like, even thyroid. If I mentioned if you had a total thyroidectomy, once you have that proper dose, that's probably never going to change. As opposed to if she still has her thyroid, and that's, I don't mean to get off on that subject. But
So generally, when you're replacing someone's estrogen, you mentioned progesterone as well. What other hormones are kind of bundled together typically?
we have estrogen and progesterone. And then it's not uncommon for a woman to complain of low libido. But part of the panel I run is her testosterone, and not just her total, but her free testosterone. So that's the active component to it. And if that level is below normal or the very low end of normal, and whether she has libido symptoms or not, that hormone should be brought back into the mid-normal range too. Okay, just like in the male, his hormone level should be brought back into a normal range too.
Right.
One of the really interesting things in talking to you about this concept of replacement is so Kaiser, if that's the company that actually suggested this, recommends 10 years or something. At some point it gets cut off. I tend to, and I'm sure most other patients tend to think of medications as something that fixes a thing. But in this case, you're replacing something that my body used to produce.
Correct.
Or her body used to.
That is correct.
Produce, and that means it's forever.
Correct.
Right? And there's a psychological thing there too, I would guess. Right. In addition to people being concerned about potential negative physiological repercussions, nobody likes to go on something forever. How do you navigate that with women?
Or men.
Or men.
Yeah. Well,
or is it even an issue?
it's not an issue, because if I tried to say to a woman arbitrarily, well, okay, you're going to go off your estrogen now, she probably would shoot me. I mean, she would. Have you ever seen the T-shirt years ago? It used to say, "I'm out of estrogen and I have a gun."
Wow.
No, I haven't.
I
That's
mean,
funny.
There's replacement is a good word you use, because that's physiologically what we're doing. This is a natural hormone substance. It had a specific purpose in reproduction, but it turns out it has a specific purpose in women now who are living far beyond their reproductive years. Millions of years, this was not an issue. It's less than less than a century. So replacement is just that, as opposed to treating a disease, an entity, okay, that then you're going to treat it until it's fixed, then you don't need to treat it anymore. Okay, they're two entirely different subjects.
Okay. So we're running out of time, but I wanted to get one more question in.
Actually, I wanted to get one more.
Okay,
too.
well, you can have your one as well.
Okay.
Let me get this one in. When is the ideal time for you to get a hold get your hands on a female patient? What period? Like, was that your question?
That was actually the same.
Yeah. Great minds. I think. Is it 51 years old? Is it when they first start experiencing? Just kind of give us some details about that.
To get a hold of her, for me, implies that I get to educate her. Okay, so I would educate her throughout her reproductive life that the hormones she has now, are going to be terminating at some point naturally around the age of 50.
So you're speaking to Jessica now.
Yeah, sure. So, but I want for you to educate yourself to become well informed, Jessica. So you don't, because you're going to hear lots of negativity. You're going to hear for the rest of your life, I predict, estrogen causes breast cancer. Or if your mom had breast cancer, you can't be on estrogen. Okay, we know that's absolutely not true. Okay? But you're going to, so to educate yourself that you are comfortable that when the time comes, okay, you're open to yourself to consider, is this appropriate for me and do I want to start this? Okay? I believe if you educate yourself well, it'll be a clear-cut yes. And
Whenever that happens.
Whenever that
Some
happens.
younger, some women much older.
I've had ladies enter menopause in their late 20s.
Oh,
Whoa.
wow.
Jeez.
So,
Yep.
yes.
Sad.
But we know that we've defined menopause as being cessation of absence of menstrual period for 1 year. But before she's even stopped menstruating, we know now the physiological changes taking place in our body's production of cholesterol and everything related to the products that present risk for plaque began 2 to 3 years prior. Okay? So the changes are already taking place while the estrogen level is winding down, fluctuating a great deal before it finally just ends. And so if a woman's having menopausal symptoms, hot flashes, night sweats, she can still be menstruating and have symptoms. She needs to be on replacement estrogen, even though she's still on her menstrual periods. You do that in such a way, okay, that it's safe and you don't stimulate her uterus to have abnormal bleeding. But yes, you start it whenever she becomes symptomatic or the time that she's stopped menstruating.
I have one more question. Do you start testing women's sex hormones, run sex hormone panels early on throughout their lives as a patient, or when they start experiencing issues that you would think are related to dropping estrogen levels?
When they experience
that's when you start
issues
testing.
and symptoms, right?
Okay.
Because if a woman's menstruating, she has to have normal ovarian production of estrogen, ovulate, and have progesterone. Otherwise, she wouldn't be doing it. So there's no reason to measure it. But if you did measure it, you have to define exactly what phase in her cycle she is. Because the hormone levels are drastically different at different times of her menstrual period. Okay? So it's not helpful at all. Okay? When a woman is entering menopause, she's not sure if she's having symptoms, not pause like that, you're going to run a hormone panel and see what it is. But it can be misleading because I've had patients who have all the classic symptoms, still menstruating occasionally, not regularly, but occasionally, and I get an estrogen level on her, and it may be in the low normal range because the range of, quote, normal is pretty broad. And I put her on estrogen. I can bring her level up into the upper part of the normal range, and her symptoms go away. Now, am I going to convince her she doesn't need estrogen now because her level was in the normal range to begin with? No way.
So you treat according to symptoms, not necessarily with the labs.
Yes. Well, yes, completely.
Yeah.
Yeah. I use the lab when I'm managing a patient's hormone replacement and something doesn't fit. She's not responding the way I anticipate it to be. Okay? And so then I'll use the lab level to kind of correlate with what I'm doing and what I need to make some adjustments, otherwise wouldn't be apparent. Otherwise, they're not that helpful.
Yeah.
But today it's a racket, okay, in terms of doctors, quote, who treat hormonal replacements. They have women come in and check their hormone levels on a regular basis, you know. It's totally a racket. It's not necessary, okay, at all. You just treat the patient, not a lab slip.
Right, right.
Well, I love this interview. Thank you so much for joining us.
Thank you so much.
I love the topic. It's so important. It's so relevant to our population and to our listeners. So thank you for joining us. How can people find out more about you if they want to reach out?
All the things we've talked about and a lot more you can find on my website. It's just GordonGunnMD.com.
And that's G-U-N-N.
G-U-N-N, G-O-R-D-O-N, G-U-N-N-M-D.com. And under the health article section, all these articles are listed in there, and they can print them, read them, all the references and authorities I list for everything I write, so you can check them all out. There's a couple of new ones out that is really, really good on this subject. One I want to comment on because I think it's really important. There's a book that was just written the end of last year that was published called Estrogen Matters. And it's well written by medical oncologist, endocrinologist in Southern California, Dr. Blemming, and everything I mentioned today you'll find in a lot more detail and a lot more examples in this book. But it's an excellent summary of what we know today in 2019.
And that article you mentioned earlier about the Windex is called Estrogen and My Sense of Well-Being, right?
That's correct.
Okay. Thank you so much again, and this is it.
Excellent. Thank you.
Thank you all very much. Thank you for the opportunity.